will stay suspended in the air. There's also been this belief that only large droplets are emitted close to the patients and smaller droplets at a greater distance. And that's where the 1 to 2 meter rule comes from. It's this belief that beyond 2 meters, there's no large droplets and you're not at risk. And this has kind of driven hospital infection control for over 80 years. It's based on very, very old experiments from the 1940s using very blunt cameras. But new research shows that both small and large droplets can be present close to the patient, and large droplets can travel far further than 2 meters. So this is a study that we did. One of our PhD students is the first author, who looked at what is all the evidence for horizontal transmission, and this is it. This is the only evidence. There's nothing else. Well, there are some studies on SARS-CoV-2 now, but they don't measure droplet size, just how far the virus can be found from the patient. And all of the studies except these first two really show that the distance can be greater than 2 meters, even up to 8 meters. So that 2 meter rule is a bit of a, it's just not correct. At the beginning of the pandemic, probably around February, the WHO was telling us that SARS-CoV-2 is spread by droplets in contact. Well, that's not based on any data. It's just an assumption. And there's been a lot of shifting goalposts around trying to disprove airborne transmission. And one of the common arguments that's being used now is the R0 of SARS-CoV-2, the reproductive number, which is the number of secondary cases that one infected person will infect. And the R0 for SARS-CoV-2 is about 2.6 to 3, and measles is about 18. So the justification that people are using is saying, oh, the R0 of SARS-CoV is much less than measles, therefore it's not airborne. R0 is not a measure of transmission mode. It's a function of the pathogen, the host, and the environment. And the other factor is that there are infections like TB, which are airborne, but which have much lower R0 values. On the other hand, there's pertussis, which is said to be droplet transmitted, but has an R0 of 16 to 18. And the other factor is that the infectious dose of the virus differs, or the pathogen. So TB has a much higher infectious dose than measles. Measles, you probably just need one variant to infect you, but TB, you need a bigger dose. And that also explains the differences in the transmission or R0 of different airborne pathogens. We don't yet know the infectious dose of SARS-CoV-2. Interestingly, measles and TB, both of which we accept are airborne, have never been isolated from air samples, whereas SARS-CoV-2 has from multiple studies. Really, I think when you're thinking about clinical practice and where you work, it's the air we breathe that matters. If someone is emitting large droplets near you, they'll also be emitting fine aerosols, and aerosols are generated just by breathing, by talking, by singing, shouting, coughing, and sneezing. We think only about coughing and sneezing, but just breathing emits aerosols. And coronaviruses tend to be more aerosolized than other respiratory viruses. Medical procedures too can cause aerosolization, but there was a recent study showing that a cough generates more aerosols than intubation or extubation. Which is then really throws into question this idea that you only wear a respirator if you're doing an aerosol generating procedure. Toilet flushing is the other thing. Toilet flushing causes a large upward transport of virus of aerosols. 40 to 60% of the particles rise above the toilet seat, so you can get quite widespread dissemination of aerosols in a toilet. And of course, the virus is shed in the feces, so the toilet can be a highly, highly contaminated zone. A lot of hospitals don't have lids on the toilets as a policy, and that's a problem in terms of infection control. So aerosols accumulate in closed settings, just like cigarette smoke. You know? There's no ventilation or poor ventilation, the aerosols will just keep on accumulating. So if there's one infected person in there, whether it's a healthcare worker or a staff member or a patient who's infected and doesn't know they're infected because they're asymptomatic, it's not just a one-hit thing, you know, that someone just coughs and a droplet lands in your eye or your nose. It's a cumulative exposure of breathing in these accumulated aerosols. Ventilation makes a big difference. It disperses the aerosols. 1 minute of loud speaking could produce thousands of oral droplets per second, and of these, at least 1,000 virus-containing droplet nuclei can remain airborne for more than 8 minutes.
Raina, Michael Fasher has a question. Can he?
Sure.
Michael,
Yeah,
can you unmute yourself? Michael? Okay, I'll ask his question. His question is, oh God, it was there. It's gone.
Raina, it's the inside-outside question.
Yeah.
What does the science tell us about the belief that we're at less risk outside than we are inside? I think.
Yeah, no, that's definitely very the case, that outdoor risk is much lower than indoors because the aerosols dissipate. It's like putting a drop of coloring into a fish tank versus the ocean. You know, you won't see it in the ocean, but you'll definitely see it in the fish tank, and the more you put in, the more you'll see it. So and all the big outbreaks that have been observed have been in indoor settings. You know, the choirs, the restaurants, the aircraft, buses, etc. It's all been in closed settings. So
what about American election rallies?
Yeah, if they're outdoors, I mean, obviously shouting increases the aerosol generation. So there is a risk, especially if you're standing, you know, really packed in closely with other people, even if it is outdoors. In terms of mass protests that happened, like the Black Lives Matters protests that happened in May and June, there's one study that suggests that maybe it resulted in increased transmission, but generally not, especially if people are wearing masks. So I think, you know, outdoors is safer than indoors. If you're going to have a rally, outdoors is probably, you know, a lot safer, especially if people are wearing masks. So this is a study that looked at the dose of virus with RNA in it, that RNA particles that accumulate with and without air purifiers. The dotted line is the inhalation dose, and the solid line is the generation dose. And the red lines are without air purifiers. That's the, you know, those portable things you can buy which have a HEPA filter in them, and you just switch them on. You can buy them at Bingley or Harvey Norman or whatever for, you know, a few $100s. And you can see the huge difference it makes. Basically, over time, which is the x-axis, 120 minutes, you can see that there's just a continual accumulation of these aerosols and virus concentration. And what you're breathing in becomes more and more risky as time goes on. Whereas if you've got the air purifiers going, the risk is much, much lower. These are all the studies that have shown airborne SARS-CoV-2. The first 6 studies are all from hospitals where there were COVID patients, and all of them found SARS-CoV-2 on the air vents, often at the ceiling level, very high up. 5 of them found viral RNA in the air, and 2 of them found viable virus in the air. There was persistence of aerosols greater than 2 meters up to 4.8 meters from the patient, and the viral shedding was highest early in the illness. And then the second last 3 studies are experimental studies where they actually aerosolized the virus and looked at what happened to it in the air. And all of them demonstrated viable virus in the air up to 16 hours after aerosolization. The last study was from Italy in an industrial area of Bergamo, where they detected viral RNA in the air at the height of the epidemic in Italy in March or April. This is one of those studies showing all the other sites which were positive for virus, and this is consistent with a whole lot of different studies that have been published now showing that you can basically find the virus everywhere, on the floor, on the chair, on the locker handle, the bed rail, the toilet seat and the flush, and the air exhaust fans and the light switches.
Raina, can I ask a question on this?
Yeah.
There, I see people spraying madly around the floor or some of the handles and things like that. How effective is that? Just they don't necessarily wipe them down, but just generally spraying the chair and
Yeah, it depends on what you're using. If you're using something that's 60% ethanol, it's highly effective. Yeah, and even for the air, the dose of aerosols that you say you've got virus in the air and you're spraying Glen 20 or whatever, the amount of spray that comes out is vastly more than, you know, what comes out when you're breathing. So it should just overwhelm the whatever's in the air, but definitely for surfaces as well. And the good thing about the sprays, that can get into the little cracks and crevices, which a wipe over can't do.
okay. And there's a question about mobile phones.
Yeah, there's been a couple of studies that have shown the virus can survive for quite a long period of time, days, on a mobile phone surface. So yeah, that's another, you know, any high touch items or surfaces should be cleaned regularly.
Thank you.
This is one of those studies, the experimental study that shows on the left the electron microscopy of the virus, showing that it's a whole virion, not just viral RNA. And on the right-hand side, it's comparing it to MERS in the red and SARS in the blue. SARS-CoV-2 is in the green, and it's looking at the spray factor, which is a measure of aerosolization. And you can see that the SARS-CoV-2 is more aerosolized than MERS or SARS, which were both accepted as being airborne. So it's really quite ridiculous to be saying it's not airborne. There's been also a bunch of outbreaks in closed settings that have supported airborne transmission, including shopping malls, buses, restaurants, a call center, and a choir. So they've all had very high attack rates, really high rates of people getting infected, and no history of contact, direct contact or close contact between the source case and the people who got infected. There was this one outbreak in China, which was in an apartment block, and it's similar to the Amoy Gardens outbreak from SARS, which you may remember, where the virus spread up several floors of an apartment block and to adjacent buildings. So in this case, it was just in the one building, but the infected people were on the 15th floor, a family with infection. And there was a vacant apartment directly above, and the whole bathroom was just covered in virus everywhere. So it had been aerosolized up the sewage pipes and into the bathroom of the floor above. And 2 people on the 25th and 27th floors also got infected. I'll just harp on again about toilet hygiene, because this is an important part of any medical practice, your toilet. And, you know, this is an important route of transmission by aerosolization of fecal material from toilet flushing, etc. One of the studies found a 4 times the risk of infection in household contacts if the index case had diarrhea. There was another outbreak on a plane where people wore a respirator the whole time except when they went to the toilet and got infected. So I think, you know, flushing with the lid down, maybe have a sign in your practice saying, please put the lid down when you flush for infection control. Keep a window, if you've got a bathroom with a window, open the window. Turn on the vents, use disinfectant. That's a really, I mean, if we're having community transmission, you really have to focus on toilet hygiene in your practice. This is a study that really outlines all the evidence.
Raina, just before you leave the toilet, how useful is this monitoring of effluent stations?
Yeah, extremely useful. You'll recall we had an outbreak in southwestern Sydney recently, and there was some cases in Camden. About a week or 2 before that, they picked it up in the sewage in Camden. So it is a really good early warning system. I think in Victoria, they need to be using it widely, get a signal that whether there's community transmission happening or not.
And Raina, there's another question about how often should you be spraying?
Every time the toilet's used.
No, just even in the room, like in the doctor's surgery. Some
I'm not
doctors
sure
are,
that. I think ventilation is probably the most important thing for the room, that surgery. If you've got a window, keep it open. But get a HEPA one of those air purifiers, you know, a HEPA with the HEPA filter, and have it running. That's probably more important than spraying, but you can spray after each patient, you know. So that same paper used these criteria called the Jones-Brosso criteria for plausibility of airborne transmission, and SARS-CoV-2 gets an 8 out of 9, which is very high plausibility, and it scores higher than SARS-CoV-2. This is a nice paper that's worth you looking up. It's open access. If you just look up Lydia Morawska, who's the person who led that letter that challenged the WHO on airborne transmission. She's at QUT in Queensland. Just look her up and look up this paper. It's a really good paper which explains all the steps you can take to reduce the risk in an indoor setting. It's all shown there in the diagram. This is we've done a bunch of research visualizing respiratory emissions, and these are emissions that you can't see with the naked eye. We visualize them, but if you were just in the room with this person, you wouldn't see any of that. And we've done experiments looking at it with masks, without masks, and different kinds of vocalization. And it really does generate a lot of aerosols. Wearing a mask, the principle of wearing universal face masks is that, firstly, it protects well people from inhaling contaminated aerosols. So there's the well person with the mask who's come into contact with a sick person who's generating infectious aerosols. But of course, if both people wear the mask, then it's much more protective because there's fewer aerosols coming out. And I'll see if I can get this video to show. I'll just have to stop share and share again.
I'm Dr. Amy Killen. I have my own medical practice, and I've been using Doodly now for a few weeks to create these really fun videos to share with patients, prospective patients on social media.
Hi, I'm Brad Callen, and in this video, I'm going to show you how anyone can
just
quickly
trying
and
to
easily
find
create doodle videos, just like the one you're watching right now.
Sound not. Here we go.
Can you see that?
Yes, it's coming up. Yeah.
Okay. So this is Bloomberg did a thing on our research, which just shows some of the highlights of the clips. The top is no mask, bottom is 2-layered cloth mask, top right 1-layered cloth mask, and the bottom right is a surgical mask. And you can see that 1 layer does prevent some aerosols, but 2 layers is better. And a 3-layered surgical mask is even better. And you can see that's just speaking. Look at the amount of aerosol that's coming out just when somebody's speaking.
And N95s?
We didn't do that in this particular study. Just go back to the PowerPoint.
Raina, there's a question on how to dry hands after toilet. Air dryers, obviously not.
Yeah, look, I mean, an air dryer can obviously generate aerosols, but if your hands are clean, it's probably not a big problem if you have washed your hands properly. Sorry, I'm just going to have to turn that YouTube off. So in terms of thinking about it from an occupational health and safety viewpoint, it's good to think about a risk analysis framework where you look at what sort of premise is it? Is it low occupancy? Is it high occupancy? How many people are in the waiting room at any one time or in the practice? Is it outdoors or indoors? I think the idea that some testing clinics have had to do it outside in the car park is a very good idea. Is it indoors and well ventilated? Is it poorly ventilated? What sort of activities are going on? Is there just silent speaking, shouting? And are there masks being worn or not? And then you can kind of work out the risk for where you are. This was a nice paper in BMJ. So airborne transmission of SARS-CoV-2 is real. The WHO modified its position to accept airborne transmission in indoor settings in July. There's more evidence actually for airborne transmission than there is for other modes of transmission, and numerous outbreaks that are highly supportive of airborne transmission, and also high rates of infection in healthcare workers who are just wearing a surgical mask. That's just to show you, that's healthcare workers in Victoria with their surgical mask and face shield and flimsy apron, gown. And there's the cleaners going into the TAB on the other side after one COVID case has been in the TAB and left, right? So the healthcare workers are going to be face-to-face treating patients with COVID, more than one patient, and the cleaners are going in after the. So somebody cares more about the cleaners are being well looked after in terms of their occupational health and safety. They've got Tyvek suits, they've got elastomeric respirators, they're well protected, but the healthcare workers really are in substandard PPE. Are we out of time?
No, we got time. We got
Okay.
only halfway. We got still half an hour.
Okay. So health workers are known to be at risk of all infections: influenza, meningococcal disease, measles, hemorrhagic fevers, and COVID-19. And any healthcare facility is generally a closed indoor facility where aerosols can accumulate. There's been previous studies of influenza showing that it accumulates in the air and can be detected in the air even hours after the patient has left. So any health facility should be thought of as a highly contaminated environment. The interesting thing about healthcare and occupational health and safety is that the occupational health and safety pyramid, which tells you that elimination is the ideal strategy. You have to design out the risk or substitute it, and then apply engineering controls, administrative controls, and PPE as the last resort. This is one of the reasons why PPE has been so neglected in health workers, because people keep talking about elimination. But these kind of pyramids were designed for industrial accidents, for physical injuries, not for doctors treating patients with infectious diseases, because in that case, the hazard actually is the job. For a health worker who's got to treat a patient with COVID, the hazard is the job. You can't eliminate it. You can't substitute it. You can't say, okay, I'll have measles instead. You can use engineering controls, which is where you bring in the air conditioning, the HEPA filters, opening the window, etc. And you can use administrative controls, which is, cohorting your patients, having different rules for different types of patients in the waiting room, making your staff and patients wear a mask. And then at the last resort is the PPE, but often in practice, it's the only thing that healthcare workers have. We know that in Victoria, there were over 3,500 health worker infections. Amnesty International released a report saying there's been over 7,000 health worker deaths in the world documented. 2 studies in NHS trusts in the UK found 1 in 5 health workers infected. There's been a large nosocomial outbreak in the Netherlands that spread from hospital to hospital. And as I showed you before, there's been a bunch of studies showing very widespread contamination of the ward area, even distal to where the patient is. So down the corridor, in the pharmacy, in the nurse's station, etc.
Raina, can you explain more about HEPA filters? That's from Michael Burke. There's a question.
Yeah,
Is there?
HEPA filters are filters that filter out very fine aerosol particles, you know, in the sort of 3 to 5 micron range. And often they contain carbon or other, they're quite thick. When you can buy those, they're called air purifiers, you know, for people. Sometimes people with asthma buy them in the home. People who are exposed to bushfire smoke might buy them, and that they've got HEPA filters in them. So the
do you put
aircraft.
them on? Do you put them on the air conditioning system, or do you just put them in your room, or?
I don't know if you can put them on the air conditioning system. Air conditioners often have good filters on them, but typically they won't be of the same quality as a HEPA filter. The problem with most air conditioning systems, the kinds that you might buy for a private practice, is that they recirculate the air. They do not have any option on them to get fresh air in, to get new air or to change the air. Those are the kind of ventilation systems they've got on planes, aeroplanes, where they do change the air. Hospitals are designed with ICUs, etc., are designed to change the air. So but some of the studies of contamination have shown that even with 12 air changes an hour, they've still isolated the virus in the air. But in terms of a GP practice, I think, you know, just getting one of those air purifiers with a HEPA filter, it'll say it on the packaging, and just having it running in the room will make a difference, as you saw in that graph I showed at the beginning. This is another one looking at seroprevalence in the US in 13 different academic health centers and medical centers, 0.8 to 31%, with a median of 3.6% of health workers infected. This is that outbreak in the Netherlands, just showing from hospital to hospital and sort of a huge spread of infection across different hospital systems. This one is a study where they tested everyone presenting for antenatal care. So these are young women, and it was during high community transmission in the US. And when they screened everyone, they found that 15% were infected, and the majority of those, 13.5%, were asymptomatic. So if you've got a lot of community, if we have a situation where we have high community transmission and you've got patients coming in, they may well be infected and asymptomatic, especially if they're younger people. Also,
So
there've been
that's screening by PCR nasal swab, is it?
yes, nasopharyngeal swab, yeah. Not serology. That's active infection. And then there's been countries that have had very few healthcare worker infections, and they've generally gone for the full PPE for people treating SARS-CoV-2 patients: Taiwan, China, Singapore. In the UK, the anaesthetists and the rate of deaths was much, much lower in anaesthetists and ICU specialists compared to other doctors, because they were, they had higher level PPE, including respirators. There was a Lancet meta-analysis which found that surgical masks had 67% effectiveness, N95's 96% effectiveness, and this was against the beta coronaviruses. Most studies have shown higher risk of infection in nurses than other staff, but there's many more nurses than there are doctors, for example, in hospitals. I haven't seen many studies that have actually worked out rates in doctors versus nurses. But we've also seen workers with no patient contact, like ward clerks, cleaning staff, food handling staff, also getting infected, suggesting a distal risk beyond the patient care area, which is consistent with airborne transmission. So before the Victorian resurgence, we started collecting information from the media, because there was no consolidated reporting of infections in healthcare facilities. And The interesting thing to note here is you've got the big outbreak in Tasmania with 84 infections, but the number of staff quarantined is huge compared to the number of staff who are sick. So it can actually shut down your whole facility because everyone's off quarantined. That's the epidemic curve in Victoria of health workers, and you can see that nurses and aged care or disability workers were the comprise the majority. The medical practitioners are in the green. But again, we really need to work out a rate because there's many more nurses than there are doctors. So just again to reiterate that aerosol generating procedures include medical procedures, but they also include breathing, speaking, shouting, coughing, and sneezing. And the thing is, if you're in a room with a patient, the patient may only sneeze or cough once or twice, but they breathe continuously and they speak much more frequently than they cough or sneeze. So the net aerosol generation from the breathing and the speaking will end up being much more than the single cough or the single sneeze. The term aerosol generating procedures probably became popular after SARS in 2003, where there was one small study that showed an association between transmission to health workers and the use of endotracheal intubation or non-invasive ventilation. And this has been used to infer a causal relationship, but really there's not good data. And like I said, there's been another study just published that showed that coughing generates more aerosols than intubation or extubation. This is a study that we did some years ago now for other respiratory viruses, and what we called high-risk procedures are aerosol generating procedures, and they did result in a 3 times higher risk of respiratory viral infections. This is just a meta-analysis of data from the trials that we did on masks and respirators in healthcare. And just look at this. Basically, surgical masks were not significantly protective for any of the outcomes. And mostly you had to wear an N95 continuously for it to be protective. But for droplet infections, so for infections classified as droplet transmitted, again, N95s protect better than a surgical mask, which just tells you that that the classification of droplet and airborne is an artificial false classification. If your so-called droplet precautions are not significantly protecting you against so-called droplet infections, but an N95 is, it's telling you there is a substantial component of aerosol transmission as well. The SARS Commission was like a royal commission held after SARS in Toronto. There was a real tale of 2 cities in Vancouver and Toronto. They both saw their cases at about the same time in 2003. In Vancouver, all the health workers were indicated a respirator. In Toronto, they just kept on saying the same things we're hearing today, which is that it's only spread by droplets and contact, and they were given surgical masks. They had a massive outbreak and several health workers died. So because they were refused proper PPE, and the SARS Commission concluded that there was this argument about droplets and airborne, and the point wasn't who was right or who was wrong, but that when it comes to safety of workers, we should not be driven by the scientific dogma of yesterday or even the dogma of today. We should be driven by the precautionary principle that reasonable steps to reduce risk should not await scientific certainty. And it's just such a shame we haven't learned from that.
Raina, do you have a picture of a respirator N95 mask? People are just asking about what a respirator is. That just the N95 mask?
So you can get the disposable N95s, they're respirators. So a respirator is something that's designed as respiratory protection. A surgical mask is not designed as respiratory protection. It's designed to stop the surgeon from infecting the wound or just protect the surgeon from splashes of blood or liquid. masks are not designed to protect against respiratory illness. Whereas respirators are designed, they're designed both to filter and to fit. The fit is necessary for the filtration, because if it doesn't fit and create a seal, the air will just pass through the gaps unfiltered. So it has to be forced through the face piece, and to do that, it's got to be sealed properly. So a respirator needs fit testing, because there's a wide variety of different kinds of respirators, and some of them don't fit as well. Also, particular face shapes may not suit some kinds of respirators. It really is important to do the fit testing. In any other industry, it's required, and if you tried to not fit test, you'd end up being prosecuted under work health and safety legislation. Seems like it's only in healthcare that it's very lax. So the other types of respirators are the reusable ones, which are like the elastomeric respirators that you saw the cleaners wearing in the picture I showed before. They have cartridges with filters that you can remove and replace, disposable filters, and you can disinfect the whole unit and reuse it again. Many hospitals in the US, when they ran out of respirators, procured elastomeric respirators for their staff and just reused them. You can probably work out a kind of risk analysis framework for your patient for working with during the pandemic, similar to the one I showed before, but this one is looking at age, but also comorbidities and what kind of work they're doing. Other occupational considerations are healthcare worker age, comorbidities, clinical role and procedures, and also subspecialties. So any doctor who's dealing with who's doing procedures of any kind, as well as dealing with patients who are either cognitively impaired or mentally ill, would be at increased risk, because, patients who are obviously cognitively impaired or mentally ill may may not be able to follow the recommendations on what, wearing masks and covering their mouth when they cough, etc. Non-clinical personnel are also at risk. The receptionist is probably at high risk because they're in a crowded waiting room with lots of people and they've got to sit there all day. So it's probably a good idea for your receptionist to wear a mask. The cleaning staff as well are at risk. So I might just briefly touch on vaccines. Are there any questions?
Yes, there are a few. Michael Burke has a couple of questions.
Thank you. Thank you, Smita. I was just asking, I'll just go to my questions. I mean, just in the reality in everyday practice, we like to have a cup of tea, and there's always a tendency to want to take the mask off when there's not a patient present. How risky are those kinds of things?
Yeah, I think that's okay. Just spray your room with Glen 20 before you have your tea break.
Right.
That's what open your window. If you've got a window, open it,
And Rhino, we have the situation more and more now where people are actually refusing to have tests.
As in patients?
As in patients, yeah.
Right.
And
Yeah.
there's similar to that, they come in, they've done the screening at the front door, they haven't disclosed anything, they get into the consultation, and then they say, oh, I've got a fever, I've got a sore throat, or they cough,
So I think it's probably important to try and ascertain why, are they afraid they'll lose their job, they won't be able to work, are they, if you can try and get to the bottom of what the fear is about getting tested. If it's fear of the actual procedure, I think there's, over time, there's going to be more and more rapid tests available that are less invasive and give you a quick answer. Some of them will give you an answer in 15 minutes. There's been a lot of development of rapid tests. There are several that are TGA approved already in Australia, so maybe those will make it easier. There's salivary tests as well, which are good for kids and people who don't want, the nasopharyngeal swab. So there's a few different options.
And is there any way of sort of best guessing the number of likely new waves we're likely to see in the next 12 months?
It really depends on the vaccine development, you know, when we get a vaccine and when we get enough of it to vaccinate everybody. The other thing is, you know, at the moment, I've estimated we probably vaccinate about 5 million people a year with the infant and the adult programs, as well as the school-based programs. But we're talking about having to vaccinate 26 million people, and we want to do it within 1 to 2 months. You don't want a slow trickle. You need to get the vaccine uptake high quickly. You know, maybe GPs are being expected to just do all that vaccination. Will you have time to do anything else if you have to vaccinate, you know, 4 or 5 times as many people as you do now?
Yep, very much.
It's
Right.
worth thinking about. I don't know how much planning has gone into the actual infrastructure and human resources requirement to vaccinate. You know, should practices be getting nurse vaccinators in, you know, to plan for all of that? It's something that maybe the RACGP should be actively canvassing with the government.
Raina, it's Michael Fasher. Am I wrong to be thinking the take-home message for me at work is to not go there without Glen 20?
It depends on, you know, what other measures you can take. If you've got a really well ventilated office with windows that can be opened, especially going into the summer months, and you can keep them open all the time. Personally, I think aerosol transmission is the dominant mode of transmission, probably more close up than further away, but it's still a risk in indoor environments. We have seen outbreaks in GP practices, and lots of GPs got infected in Victoria during the second wave there. So I think avail yourself of everything that can help.
The problem is, isn't it, is that the protecting yourself against droplets is much easier at the end of the day than protecting yourself against aerosols that hang around, because there wouldn't be a doctor in this room that doesn't take off their mask when they're not in front of a patient. And what I've learnt from you tonight is that the patient doesn't need to be there to have left their COVID.
That's right. The ventilation, opening a window is probably the single most important thing you can do. It really dissipates, just a little bit of ventilation will really dissipate those, it won't allow the aerosols to accumulate.
So in my setting, that would be opening an internal door. I don't have an external window.
Right. So I would definitely get one of those air purifiers and have it running, and have a can of Glen 20 in the office. Honestly, I use it all the time. If I have tradespeople coming to the house or even visitors, I'll spray it before they come in and I'll spray it after they come in. I'll open all the windows and doors. I'll let the fresh air in. You know, I'm really super careful. Yeah, because I think some of the evidence suggests it is, you know, aerosol transmitted.
This has been really, really useful. Thank you so much.
Raina, you talked about fitting of masks. Who does the fitting? Is it a personal fitting? Do people do it themselves?
You can get an occupational hygienist to come and do it. That's the best way to do it. You contract with an occupational hygienist to come once a year and fit test everyone. You need to do it annually because people lose weight, gain weight, you know, their face shapes change. So you need to have it done annually. I might leave the last few minutes for questions rather than, happy to talk about vaccines if there's questions about that, but I was really going to cover more the scale of vaccination that needs to happen, and it's going to fall on general practice largely. And it's something, you know, that needs to be planned for and thought about.
Well, one of the things that general practice has very successfully done, Raina, is set up GP-led respiratory clinics for testing. I just wonder if we're not looking at, you know, setting up clinics that can vaccinate the population at large very quickly.
Yeah, I think the same model that's been used to do the testing clinics that lots of GPs have set up could be done for vaccination. You know, you have some nurse vaccinators there as well. And, but, you know, we haven't got many nurse vaccinators at all in Australia, not for the scale of operation we require. So I think, I don't know, I think you know, I think if RACGP could sit down and come up with a plan and do some numbers, some calculations on how much volume is going to have to go through general practice, and then go to the government for, you know, funds to train new nurse vaccinators, for example, you know, to create positions for nurse vaccinators. And because there's going to be, you know, a requirement for quite a scale up of capacity to vaccinate.
You know, I beg to differ a little. I think that it won't be, I mean, as loyal as I am to the RACGP, I think this is going to be an LHD-PHN partnership that pulls this off.
Yeah.
And at the end of the day, we're going to have to think in extremis of not using professionals. I mean, I can train lay people to vaccinate pretty quickly.
You won't be able to do it with this vaccine because these are new vaccines with significant safety concerns. It's not like giving the flu jab. You know, I don't think it's probably initially, even pharmacists won't be allowed. My guess is it'll be doctors and nurses, nurse vaccinators.
Could you talk a little bit more about why that is with the new vaccine?
So it's a brand new class of vaccines that, you know, the other vaccines that we have on the NIP have been, the NIP, are tried and tested vaccines, and we know the safety profile. There's no major issues. They're all really safe. With these vaccines, with the kind of, there's concerns about serious side effects. One of those is antibody dependent enhancement, which is where being vaccinated makes you get the disease more severely rather than protects you against the disease, which is what we saw with the dengue vaccine, and has been seen with some other vaccines in the past, also with the SARS vaccine and the MERS vaccines. And also we heard about the AstraZeneca trial being halted because 3 patients developed transverse myelitis. So it's unknown, you know, the safety profile of these vaccines won't be really established for a few years when we've had millions and millions of people vaccinated, because clinical trials will pick up common side effects, but sometimes really rare trials won't be picked up on the clinical trials because they're not big enough. That's what we saw with the first rotavirus vaccine in the 1990s. It was, the clinical trials did not pick up a safety signal, but when it was rolled out in the United States into millions of infants, a safety signal came up for interception, which had not been picked up on the clinical trials. And the rotavirus vaccines we use now actually had to go through trials that had 60,000 plus participants to prove that they didn't cause interception.
So if I've got you right there, Raina, the rate limiting step in the new world is informed consent and follow-up. Am I right?
And also monitoring for adverse events, some which may be immediate, you know, that because this is a new vaccine and not one where, you know, often safety issues come up post-licensure. They don't come up during not often, but sometimes during the trials. And there's already a lot of concerns about these vaccines because of the kind of immunological aspects of the response to infection and you know, being introduced to antigens from the virus. It is a very complicated virus in the sense that you can get that antibody dependent enhancement and maybe immunological side effects like transverse myelitis.
Raina, we've got a few minutes, and I know you wanted to just share about the mask and the bushfire study, because some of the people do. Michael Fasher actually lives in the Blue Mountains area.
Sure. So we're doing this trial called the BREATHE study, which is bushfire, respiratory protection, emphysema, bronchitis, and asthma triggering health effects. It's a randomized controlled clinical trial of masks and respirators for reducing the adverse outcomes of smoke exposure in people with asthma and COPD. I'll just skip straight to the aim of the study is to see whether surgical masks, P2 respirators, or outdoor air avoidance can reduce adverse respiratory outcomes during the bushfire season in people with COPD and asthma. So people in New South Wales, Victoria, South Australia, ACT and Tasmania with asthma or COPD who live in a bushfire smoke affected area. So it can be a metropolitan area. A good indicator is if your patient said to you last summer that the bushfire smoke made them wheezy or, you know, need more medication for their asthma or COPD, then they're eligible. I mean, I live in Wahroonga, you know, and I was on I've got asthma. I was on taking oral steroids through January because my asthma was so bad from the smoke. So people in metropolitan areas would be eligible if they've been exposed to smoke previously. And then we'll just follow up there. They'll have certain triggers to use their mask, respirator, or outdoor air avoidance. And then we'll measure their exacerbations of asthma, COPD using a self-reported questionnaire and medication use. So thank you. And that's that website, that web link there is a list of resources that I've put together on COVID-19 under different headings. It's got a whole bunch of stuff on vaccines, on antivirals, on immunological things, on asymptomatic infection, outbreak control, etc. PPE as well. So you can have a look at that if you want a quick reference guide with some subheadings.
Rhina, how do we have the opportunity to participate in the mask study?
So we have, there's a website there as well. I'll send both the links to Smita and Michael.
Yeah.
Send them around to you.
Great.
So we have flyers and stuff, so you can download flyers off our website, or we can post them to you and you can just put them up in your practice if you've got patients you think would be eligible, and then they can just, you know, contact us if they're interested in the study.
And we're needing 300 people, so we're really keen to recruit. And they do get, if they happen to be on the study part where they get masks, they actually get masks supplied, so all for free. So if you know anyone, please go out there and help recruit for us. That would be great.
If you had patients who came to you last summer saying their asthma or COPD got worse during the bushfire smoke, then they would be eligible.
Thank you very much, Smita. Thank you, Rhina. I'd like to hand over to Kim Liu to give a vote of thanks. Kim. You need to unmute.
On
Great.
behalf of the Hills Doctors and our PHN, we truly thank you, Raina, for actually presenting today. And I want to personally also thank you for being so outspoken in the media during the early phase of the COVID crisis, and being such a clear voice during this whole time during the crisis.
Thank you. Can we all just show appreciation?
Thank you for those words. I appreciate that, Kim.
Thank you.
And all the very best. I know you're out there at the front line, and I've really felt for GPs, you know, being thrust into it with right at the beginning, being told, right, you know, patients have been, you know, public being told, go to your GP if you think you've got COVID, and being given surgical masks.
Yes.
Yeah.
Okay, final meeting of the year, November 24. We're listening to doctors' voices, your stories from the time of COVID-19 and the bushfires, 2020, the year we couldn't imagine. And thank you very much to everyone, particularly Rhina. Okay.
Thank you, Professor Raina. Good night, everyone.
Thanks.